of that first clip you saw, and I'd like you to look at the difference you see in the babies as the weight progresses. Okay, so this evidence was presented in 1990, and we are in the year 2020. And how many of us actually had all this information? I am very thrilled that a lot of people understand breast crawl and that the baby will crawl to the breast. But how many of us understood what lay before that? And so in 30 years, this information is not yet mainstream. People don't consider it, our doctors don't know it, we don't practice it. And so we want to talk about the reality of life, how birth is today, and majority of us may be giving birth in a hospital. So there were two words that were used, and I want to bring them up and explain them a little bit. One was unmedicated, the other was uninterrupted. And I don't just want to talk about what that means. I also want to briefly talk about understanding if we are not able to achieve this ideal of birth, what can help us? So, this isn't about what is lost, but it is about what can be recovered. And so unmedicated means that everything in labor and birth is left to unfold as nature designs it. When we talk in our childbirth class, we always talk about how everything that is happening, which may be a really smooth sequence of birth, or even things that don't go smoothly, are actually reflecting what the baby needs or does inside to facilitate his own birth or her own birth. And so when we bring in inductions, when we bring in epidurals, when we bring in muscle relaxants, when we bring in, any kind of anesthetics, we are medicating the system, which will then respond a little bit differently. And like it or not, everything crosses the placenta. We accept that in pregnancy to the point that we don't have tea, we don't have coffee, we avoid everything that might remotely cross the placenta. But yet, how do we accept that none of the drugs that we are given in birth don't cross the placenta, or they don't have an effect on the baby? We know how the mother feels, how the mother behaves, what she experiences affects the baby. So labor itself does affect the baby in different ways, and medication too does. So it's you will find that the unmedicated baby and the medicated baby, even though the reflex was there to get to the breast, the motor nerves did not work as well. And it's also because sometimes when you see epidural, our own motor nerves are kind of hindered from working fully. That is why when you take an epidural, you lie down. So medication does affect the baby. Does it affect the baby in a way that is linear? Perhaps not. So here is where I want to really expand your imagination. If the baby has a pre-coded design to do a certain sequence that facilitates breastfeeding, and for some reason is held away or it is not completed, what can you even, by the slightest stretch of imagination, think? What might the baby feel of not being able to do the very steps that ensures survival and makes them feel safe? And then if you think the word stress, imagine when you feel stressed, what happens in your body is your shoulders tighten and your jaw tightens. This is the area where breastfeeding is happening. Not to say other complex mechanisms that happen when we are stressed. So any kind of interruption in the baby's sequence, and it's a 9-part sequence to come to the breast, is actually reviewed by the baby as it's failed, because the brain doesn't have the context to say, oh, there's another way. It just says it fails. Think of it as a new computer, and you bring it up, and when you switch it on, it does a certain setup. And usually we say, while it's being set up, keep it powered in and do not touch it, because it needs to go through a sequence which is pre-coded in the computer that will set it up to work efficiently. Why is that not true for the supercomputer for the baby, which is now meeting the new world, and everything is different? Not to say what the birth may have felt like, or what was the challenge in the birth, or what was going on pre the birth. So it's a complex situation, but to simply appreciate the overwhelm the baby may feel when the things that tells him innately from his own body that he's safe or she's safe are disrupted. That brings us to interruption. Interrupted means, usually when the babies come out, their expectation is to meet their mothers. But what do? We write them vigorously, we take them away, we cut their cords, we put them into an oxygen panic, and then ultimately we also separate them from mothers. Separate them in terms that they're taken to nurseries to be observed. And I always wonder, what are you observing? Because when you look at research coming out of premature babies, we say that babies' heart rate, their blood sugar, their temperature, and all the other the breathing, it organizes or settles faster in proximity to the mother. So for premature babies, we are encouraging skin-to-skin contact, we are encouraging kangaroo care. But for full-term babies, which may be just a week later, so instead of 36 weeks, this baby has come spontaneously at 37 weeks, we feel that separating them for an hour from the mother might be okay. But what separation does for babies is it stresses them out. And our response to stress could be either incessant crying, which is an activation, and the baby can only activate, they can't run around or pace around or get upset. Or the other part could be to disassociate, which is a baby who sleeps too much and does not come onto the breast for needs of food. So what does it mean to be unmedicated and uninterrupted? This is probably the most important thing to understand when we look at babies' behavior. So a lot of us said that babies need to be taught to be sucked. Well, they don't have to be taught to be sucked. They are not sucking because they are in a state of stress response. Let that idea land in you for a moment and see, what if that is true? What if the baby knew how to suck, but now is really scared and is not exhibiting any of their old reflexes? So what to do when it becomes medicated and interrupted? Restoration of the breastfeeding paradigm is the mother and baby in proximity, which is skin to skin. So that is why you see there's so much emphasis on skin to skin now, because it is one of the restoring parameters. For a baby who's uninterrupted and unmedicated, as he arrives into the world, skin to skin is the expectation. That's where the baby reorganizes into this world and then begins to express the next behavior, which is breastfeeding or breast crawl. So we think of skin to skin as plugging in, keeping the power on. And once it's a reboot also comes, that you have to first plug it in. So bringing the mother and the baby in proximity. The second part, which is also very important, but we usually don't talk of it, is what is the mother state when the baby is in proximity. We know that our states are transferable. If we are in a room full of tension, we will also feel our heart rate go up, or our breathing gets saying. We might even begin to feel angry or upset or restless. And if the mother is in a state of anxiety and we bring the baby in proximity, that's what the mother's body is telling the baby, we are under stress. So it's very important that we nurture the mom if we want to get this sequence right. And that's the part that's usually missing when we do skin to skin. So now skin to skin is also yet another thing that you have to achieve or do. And the anxiety of getting it done or performing it is actually detrimental to that relationship together. So unmedicated and uninterrupted. If your questions pop up at this time, please put them in the chat box. We will address them. Here are some of the common myths. We have put them up for you. Breastfeeding is painful. No, it isn't. If breastfeeding is painful, no mother, no mammal will be encouraged or motivated to breastfeed their baby. In fact, breastfeeding is pleasurable, it is satisfying, and it has great psychological, physiological motivation marker in your own body in terms of hormones, in terms of neuropeptides that encourage mothers and babies to come together and bond. Bonding is one of the side effects of breastfeeding. Not enough milk. This is really a statement we hear a lot from people who talk about, I don't have enough feed, and I really don't know what that means, and I'm not making enough milk. And so we have started to think of breastfeeding from the lens of bottle, which means if I can measure, then I know how much milk I'm making. But the breasts are not made of glass. It's a very popular saying in the breastfeeding circle, and it has no markings, and it has no storage, and there is no capacity. There is a continuity of making milk, which is customized to the baby. If women didn't make enough milk, or if milk production was dependent on food and environment only, then poor and challenged women would never breastfeed their children. But they seem to be doing it quite effectively for a quite long period of time. And the third common myth that we talk about is babies cannot suck or need to be taught to be sucked, and we just talked about it. Other than a malformation or a neurological issue, babies can suck. They might be deterred from sucking from muscular tension or other things that may have happened at birth and just need to be restored by the mother's proximity and the mother's touch. So broadly, for about 95 to 98% of people, this will hold true. This will ensure success of survival of the species. That is breastfeeding. Okay. Do we want to look at the chat questions a little bit?
Yeah, so one of the questions is, people here say if baby's head touches the nipple, it will cause engorgement, mastitis in mothers. Understood it's a pure myth, but don't know how to explain and make them understand.
Okay, and then there's downside of giving formula and yes. So I'm going to answer one of them right now, which says even patients have info and ask for it. Doctors are not supporting. That is because we're expecting support in the wrong corner. Doctors are primarily educated for problems, not normal. So a doctor cannot give you nutrition advice. They can give you basic, you have to have protein. This is the source of protein. You have iron. Take this medication for iron or this tablet for calcium. But they cannot give you health. They can give you disease consult, but they cannot give you health consult. So and pediatricians specifically have about an hour of breastfeeding orientation. You are having two. So their knowledge may not be really up to date or supportive about breastfeeding. And so that's not the source you should go to. You should go to people who do lactation education, lactation counseling. There are many resources available, including a workshop like this that will orient you. Once you understand how it's done and it falls into place, then the tiny quirks can be adjusted quite easily for majority of people. The ones who do have problems, say of mastitis, can go to a lactation consultant and it can be solved by them, because doctors will only prescribe medications. They will not look at process orientation. So we're going to park the questions for now. Some of them are going to get answered as we go along, and then we'll come back to all your questions again. And I know that I am, and also Tanvi is making notes of the questions. So let's look at just the anatomy of the female breast, and I'm going to really simplify it for you because it's not complex. The only two things we have to understand is making the milk and transferring the milk or sending it to the baby. So to put it in more simpler terms to understand, production and delivery, two parts. So the red petal-like structures that you see here are the milk-making glands called lobules. And this is where the milk is made. And if you can see, they're arranged all around the nipple. And from these, the blue lines that are going to the nipple are the ducts that carry the milk to the ducts. Here's a really simple representation of what I have made at home. And so if this were your breast, and I would peel off the top layer, here are the glands. And then the ducts that take it to the nipple. And so pray, what is the role of the nipple? The nipple itself is in charge of having the openings to let the milk out, but also is highly sensitive to take information from the baby, from the saliva, in the present moment, to send it back to the mother's body to customize that milk for the baby's need in the present moment. And I'm going to let that land for a minute. There is already an organ, if you're pregnant right now, that is doing this job, which is the placenta. The placenta is clearly signaling to your body what the baby needs. And even though you are eating X grams of protein and you're having your carbohydrates, and are you really certain that that much amount of protein or calcium is going to the baby? Or is it something you don't know? So you have to start thinking of your nutrition as a larder or a store or a warehouse of nutrients from which the baby draws, both in utero and at the breast, as per their need. And their need is not constant. So as development takes place, different parts of the body need specific food and food combinations, the nutrient combinations that the baby will draw upon from the mother. And I'm trying to bring in an idea of autonomy. The baby is quite in charge of their own nutrition. And they have absolutely simple and efficient means of communicating those to the mother, the placenta in utero and the nipple while breastfeeding. And that also tells us why breastfeeding or being at the breast becomes significant for the baby to tell the mother what he or she needs. So for those of us who feel that milk is a problem or making milk is a problem, I want to bring to your awareness that nature designs us for abundance. And it designs us really, really way ahead of time. So one of the first things that you see when you get pregnant is the size of the breast increases. And there are the glands which are inside change, but also there is vascular change. Vascular change means the blood vessels become bigger, thicker, carrying more nutrition to the glands to prepare them for production. Right off the bat, the sensitivity of the nipple increases and it becomes more protruding. And that is also, and this is, we are talking first trimester. If nature is preparing in first trimester what it would need about 9 months later, then obviously nature is not planning to fail breastfeeding. And the third thing that happens is that your areola gets darker. Interesting, because babies see contrast and they become more bumpier. And those bumps are basically Montgomery tubercles that secrete a fluid that keeps the nipple clean, antiseptic, all of that stuff, lubricated, and also smells like the amniotic fluid. So it's a chemical or olfactory, which is a smelling imprint for the baby to say, come to the breast. So it's an encouragement to the baby. And this is happening in the first trimester. Milk is ready to be made, which means that the factory setup is ready by mid-pregnancy. Mid-pregnancy is 20 to 22 weeks. All women can make milk by 20 to 22 weeks of gestation. And this change occurs due to hormones. So it's an endocrine change. It's auto run. And so if you get pregnant and you have pregnancy hormones, your glands will develop and you will be capable of making milk by mid-pregnancy. The catalyst for milk, which is prolactin, is actually suppressed by high levels of progesterone, which is your hormone of pregnancy. So there's a nature's balance to say, while we can make milk, we don't need it right now because we're pregnant. Now, progesterone begins to drop when the baby is getting ready for birth. That's the change the baby brings into the mother's body by making her levels drop or her hormones change. And then, of course, once the placenta is delivered, which may be both in a C-section and in a normal birth, progesterone will drop sharply. And so when progesterone will drop sharply, right after that, prolactin will rise because whatever was inhibiting it is gone and the milk will start to be produced. But it's not a switch and it's not instantaneous. It is a progressive or a dynamic process, which means, so now let's look at unmedicated through a new lens. If the baby was allowed to carry on the pregnancy till such time the baby initiated labor, and we talk about it extensively in our childbirth class, That means the hormones in the mother's body are following a certain pattern, preparing to give birth, but also breastfeed right after that. Versus if there was a break in that timeline or continuity because of a medical reason, which may have needed an induction or even ended up with a C-section. So that time period is called a hormonal gap. And for the body to adjust to levels of hormone, it might take an extra time to integrate it. So for some women who've had medication, breastfeeding is disrupted because the milk production hasn't quite set in yet because the continuity had a break. Having said that, with the placenta being released, there will be a drop of progesterone. So milk will come in, and for majority of women, it will come in abundance, which is usually called engorgement. And this too is run automatically by the process of physiology or nature or hormones in the body. So every woman who's pregnant will develop their glands, will start to make milk, will produce milk in the beginning when after the placenta is delivered over a couple of days and reach engorgement. But thereafter, it begins to customize to the baby. And we say that the more the baby comes onto the breast, stimulates the system of the mother with his mouth, that communication, chemical communication between the saliva and the breast, and gives the body an experience of volume and quantity and quality that he's taking in, will then determine what the mother's body perceives as, now I have to make for the baby. Think of it as a guest in your home. And you have a couple of guests, but you don't know what their routines are, what they like to eat. So say for a simple thing like tea, coffee, or milk, you will get some extra milk and put it in the fridge. And then that evening that they're there saying, oh, would you like to have a cup of coffee? And then somebody will say, oh no, I don't drink coffee in the morning, but I like a cup of tea or milk in the night. So by day 2, you'll have a better idea of what your guests need. By day 3, you might only get the amount that is needed. And by day 4, you're settled in, and now you can look after your guests. Think of it in the same way. While the body knows the nutritional need of the baby, it doesn't really know what the baby needs till the baby begins to communicate it over a period of time. So lactogenesis 3, lactogenesis means production of milk or making of milk or start of milk. 1 happens mid-pregnancy, 2 happens at birth, but 3, which is the most significant, is about demand and supply. And how do we say demand and supply? It's not just how much milk the baby had, but also the stimulus to the nipple. This is the basic setup. And here are the reflexes that makes the baby initiate or efficiently breastfeed. The first one is rooting, sucking, and swallowing. So rooting is turning your head to go towards the source of the food. So if you touch a baby, hungry baby, especially on the teeth, they will turn their head and move towards that. That's called rooting. Sucking, we are familiar with, is the motion of the lower jaw, but it just doesn't involve the jaw, it also involves the tongue. And then the coordination between swallowing and sucking will help babies breastfeed. But interestingly, nature is again very much on the side of abundance here. So babies can swallow at 11 weeks. What are they swallowing? They're swallowing their amniotic fluid. And they're practicing their swallowing right from that first trimester. They can also suck by 24 weeks. So here, when we talk about baby that has to learn how to suck, or we have to teach them how to breastfeed, is negated by this idea, because this reflex starts mid-pregnancy. It's interesting because breast making capacity also starts around the same time. There is a unique synchronicity of the baby and the mother, each one helping the other come into a new level of efficiency. So the baby can suck, and what are they sucking? Often in ultrasounds, we see babies sucking their thumb, there we see them sucking, their toes. So they are giving themselves a lot of practice on sucking. But sucking also happens to be nature's mechanism to soothe themselves. So they're developing a skill where they can help themselves in slight ups and downs of life by just sucking. By 32 weeks, they can coordinate sucking and swallowing. So they and then swallow. Think of yourself chewing and swallowing. When you chew, you're breathing, but when you swallow, breath might be suspended for a second or two, and then you coordinate it back, and it's effortless. And by 32 weeks, babies can do that as well. And by 37 weeks, they can also coordinate their suck, swallow, and breathing at 37 weeks. So we know that this baby is ready to breastfeed really before they're ready to come out into the world. Again, it points to the direction that these babies don't need to be taught to breastfeed, or it's not something we have to do. It is something that will arise through them if we put mothers and babies in proximity. Here's how the hormonal interplay happens. We talked about prolactin. That's the one that produces milk. It's quite simple to understand. Pro means for, lactin means milk. Prolactin produces milk. High prolactin levels will make sure that you make a lot of milk. That's your production center or production mechanism. But there is also a psychological effect of prolactin. It modulates stress and depressive-like behavior. So it's like a buffer for the mother against lows. And you'll find that in the continuum of postpartum, you'll have a high, which is after birth, and you might have a low by day 2 or 3. And that's when you're getting engorged and prolactin begins to rise. But by the end of the week, when the milk supply settles, so does the baby blues settle. And so nature is in the mechanism of breastfeeding and the proximity of the baby, making sure that the mother is also protected. And because the mother is vital for the baby's survival. And I'm talking on a purely nature's perspective without any idea, any judgment about the father's role, mother's role, family's role. But in terms of nature, mother with her breast and the capacity to make milk is vital for the baby's survival. The other hormone, which is our pathway of delivery, the delivery system, is called oxytocin. If you've done a childbirth class or you've studied anything about childbirth, you know oxytocin is the hormone that causes contractions of the uterus. And so it has many, many effects. One of the effects it also has is bonding. That's a psychological effect. So oxytocin is the hormone which produces long-term relationships. And the more the mother and baby are in proximity, the more they fall in love with each other. So it's like a love potion every time breastfeeding, looking into the baby's eyes, touching the baby's skin, proximity. All of those pathways tap into oxytocin. And oxytocin then on the level of the breast squeezes the tissues. It's a hormone that contracts muscles. So it squeezes the tissues around the glands and lets the milk down. So it's the delivery system. Now, even though it produces bonding and reduces stress, high levels of stress hormones inhibit oxytocin. Now go back to all the women who say, I didn't have enough milk, or I couldn't feed my baby, the baby's always crying. There are multiple factors that are tying into it. Mother stress stresses the baby. Stressed baby needs sucking for self-regulation or soothing for co-regulation. To get milk from the breast, we need oxytocin, but because of anxiety, oxytocin is depressed. So a baby who needs his mother goes to the mother and feels more stress, feels the need to suck more, in his hunger, still does not get milk. Double whammy. And we are watching this interplay happen over and over again by fragmenting breastfeeding from humanity or human emotion or bonding or other things that are important for food. We are becoming very mechanical in our nature, and we are missing many simultaneous processes that might have supported it. Think about eating alone. Think about eating fast food, drive-through, and a social evening. It's the same food, but it's a very different human experience. So breastfeeding is the ultimate dining experience for the baby, where and other things you might in your mind start to imagine what they might relate to. You do eat alone once in a while, but it's not as satisfying as if you were to share a meal with somebody you enjoy it. And that is why most messes, most dining halls have, common areas for eating. And also, when we ask people out, we saying, let's meet for a drink. It's always something to do about food in our mouth. So there is a psychological effect of oxytocin, and the mother's psychology affects. So it's like a vicious circle. Either we can make it spiral to the positive, or we can make it spiral to the negative. Once again, the mother's emotional state becomes very important. And this is how it works. Okay. So let's look at the first pathway, which was stimulus at the breast. The baby's mouth is at the breast. The warmth, the moist, the saliva is sending all kinds of signals to the mother's body because it's a very sensitive place. This message that goes here produces, it stimulates the hypothalamus and then the pituitary to make prolactin and to make oxytocin. So the hypothalamus then says to the anterior pituitary, which is the front lobe of the pituitary, make prolactin, produce milk. Also to the back lobe or the posterior pituitary to make oxytocin and milk ejection. So by the act of suckling, the presence of the baby, and we're just talking about one single pathway of the breast or the nipple and the saliva. How about the touch of the baby? We know that there are oxytocin receptors on our chest. There are so many. How about eye-to-eye contact? We know that our brain feels safe when we are in a social engagement. So much more is happening for the baby, and it's not surprising that we talk about breastfeeding benefits in terms of IQ, in terms of EQ, in terms of learning activity. So much more, because the brain is being stimulated in the most holistic way, in the container of safety, with some amount of autonomy of getting self-soothing. I can manage it for myself, with the presence of a regulated adult which tells me the world is safe. So many different things happen at absolutely the same time in a simple act of putting the baby to the breast. The other part of removal of milk or transference of milk from the breast to the baby. So it doesn't matter how long the baby was at the breast. It is how effectively the baby could take in the milk. And that is directly related to the amount of milk your body produces over a period of time. So the more milk is taken out, the FIL or the feedback inhibitor of lactation is reduced. Think of this hormone or this particular biochemical as a ball valve in a tank. When your tank is full, the valve is right on top and no more water comes in. As the water level drops, the ball falls and more water starts to come in. So if there is ample supply of water, perennial supply of water, then your tank will never be empty. It will always be either emptying out and filling up at the same time. And breasts are like that. So this whole emptying out of the breast is a very strange idea. And these different communications about how much is being made, how often it is being made, what is the baby asking for, is also regulating what the milk will have as constituents or nutrition, because that's again asked by the baby. So here's my recipe of success, which is pun intended, feeding on demand, which means there is no scheduling of feeds. Once we impose our time limits on the baby, we are effectively losing the window of optimal feeding, because once the baby's blood sugar falls beyond a certain level and they get exhausted, they may not be motivated to drink as much. So we are actually disturbing the fine balance again by interacting. So feeding on demand, feeding as much as the baby wants, therefore don't looking at time to say how much time on each breast. No, that's not okay. Feeding as much as baby wants till he leaves the breast, and then often the other side. And as you begin to do that, trust me, you will get a sense of what feels adequate. It's not measurable. It's an innate understanding. And the third and equally important part is to have an anxiety-free, emotionally available mother, because oxytocin is all about mom being happy, being joyful, being settled, being calm, being nurtured, being cared for. So literally we are caring for the mother to give her a blueprint of what mothering might feel like. And she'll offer it back to her child. And of course, the biochemistry works that way. And also from the mother, the baby is getting cues of safety. Okay. We saw some hands go up. Tanvi, do you want to take that up a little bit?
Yes, so we have a couple of questions. I'm just reading them out to you one by one. One was what is the downside of giving formula milk? Uh, how can a mother identify tongue tie?
Can identify?
How can a mother identify tongue tie?
Okay.
At what constraint a postpartum lady don't have milk to feed baby?
Say that again. I didn't get that.
A postpartum mother, I think basically what she's trying to say is that a postpartum mother, if she's not able to make milk, how to feed the baby.
Okay. So I want to bring your attention to what we've already talked of. And let's talk of formula to begin with. Now, once we introduce a formula, two of the things will happen. Firstly, babies who have formula will sleep longer. I like to call it a digestive, for the lack of a better word, coma. It's like having a lot of heavy food, which you are not easily digestible. What would that leave you with? Lethargy. Try, if you're in north of India, try having chole bhature and beer for lunch today. Well, not the moms, but the dads can. And see what happens. Even though you're awake, it takes your body, it channelizes a lot of energy of your body or a lot of resources of your body to just digest that milk, that food, and for the baby, that formula milk. So formula milk is actually quite indigestible by babies. That's why at best it's giving calories and some amount of nutrition. But it's undigestible by, and it also then upsets different digestive hormonal patterns of the baby and the microbiome of the baby. But really, at the face of it, if your baby, say, has had a breastfeed at 12 noon and then is asking for milk again at about 1:30, you give him formula and then he sleeps for 4 hours. So effectively, your body has got no message of making milk or feeding milk from 12 to 5:30. What does that tell you about what is that signal say to the body about what the baby needs? So even when people say, oh, but I've only started with one top feed, you are giving that gap, effectively reducing your own supply. Whereas if the baby was, say, having a growth spurt and getting hungry more often, basically this baby wants to tell the mother's body, I need more, quantity, quality, everything. So the frequent feeding will actually increase your milk supply. It's going to be challenging, yes. So postpartum period, we traditionally shut down other drain of resources, which means no social activity, no home activity, just rest, eat, hydrate, and feed the baby. So that, especially in the early period when the baby's stomach is growing, the baby's making a phenomenal change, your milk supply is keeping up with that change. So formula will intervene. So at a nutritional level, at a level of stimulating health pathways in the body, and at the level of interacting with the mother and blood milk supply, formula gets in the way of all. So where would it be justifiable? It's, so again, I never want to say it's right or wrong. It's entirely for you to decide. So formula originally was designed by companies as medicine for premature low weight babies so that they could put on weight really quickly. That is why it's calorie rich. And so could it be something that you fall upon so that you can recoup from a place where you're outside the range of your resilience and come back to a normal paradigm? Think of it like if you're really unwell, you might say, okay, let's order our food today, but mostly you'd like to have home cooked food. Can you use it like that? That's you being wise. That's you being practical. But can it actually substitute as food? So the question to ask is, does junk food substitute as food for your child as he's growing up, or for you in terms of health? But is it tasty and you use it once in a while when you're in a pinch? That's the approach I would take towards formula rather than a clear yes or a no. And even though for some reason, if that is the only option of nurturing my baby right now, which is making his weight grow up for that reason alone, can we then start to look at at-breast behavior? So there is something called a supplemental nursing system where you can actually feed either express milk or other sources of milk at the breast, because we don't want to lose the contact, the stimulus at the breast, the safety from the mother, the loving cues of the mother's eyes and voice, the contact with the mother. Can we retain that? So instead of replacing breastfeeding, can we use the resources that the modern world has given us to make sure that our babies get the best chance forward? I'd like to place it like that. Yeah, so does that answer your question about formula, I hope? And then there are a couple of others that you asked, but we are going to address them right away. And, as we understand or orient to breastfeeding, you'll find that the answers will come to you automatically. So this is also something of great concern, especially as the baby is born, because this idea the baby has not had anything. And so it's really interesting to know what is the baby's requirement. I mean, you can give the baby whatever you want, but is he really needing it? So day one, the size of the baby's stomach is the size of a cherry. Each feed is about 5 to 7 ml, and 5 ml is about a tablespoon, not even a tablespoon, it's about a teaspoon. And at that point, you still don't have milk because the progesterone is still on its way dropping, prolactin is rising. It's a transitional period. In that period, you have something called colostrum. And this is about all you can get each time. If you pump it, you may not get, because oxytocin is about the love you feel for your baby, not what you feel for your pump. Breastfeeding is not mechanical. It is absolutely a human experience. So women who smell their baby's clothes, who think about their baby, who hear their baby cry, can actually start to release milk. And it's got nothing to do with the pump at all. And of course, layering of those experiences. So for a newborn, coming to the breast is really a significant thing. From the baby setup point of view, am I safe? My mother is here over and over and over again. From the mother's point of view, because colostrum is this much and it's easily obtainable if the baby is at the breast. Does he need a lot of food? No, but he does need a lot of reassurance. She does need to come back to mommy again and again. Mommy does need to connect from the outside body mechanism to stimulate all the parts that will then lead to a successful breastfeeding diet. Yes, they do need to come together. And with a C-section or with things that challenge mothers physically, we saw a position where the baby was effectively breastfeeding upside down. That's absolutely the right position for them to feed, no problem at all. Their suck and swallow is so well coordinated that they can actually feed in that position. That's the size. But what is more interesting for you to notice is the change that happens by day 3. That's a phenomenal change. It's about 4 to 5 times change. Now, nothing grows that quickly. The first 2 days, the baby is growing, the stomach is growing that quickly. So we can't really say what the baby needed on day 1 is what he needs on day 3. Now, by day 3, the milk comes in. As the stomach grows, the mother's milk supply grows. It's interesting, again, we are seeing the same back and forth between the baby's development and the mother's change or meeting that need. It's truly nobody can say what grows first, the baby's stomach and the excessive sucking, does that bring the milk on quickly, or does the milk supply then signal to the baby that, yeah, we have enough, growth is okay? We don't know. It's unspoken, but it is very well synchronized. And that's the difference. That's when engorgement is happening. And then as the baby frequently feeds, he grows or she grows, and the mother's milk supply also, mother's body also gets the signal by day 10. So here it says by week, it's about 9 times. A week is just 7 days. By 1 week, your milk supply has settled. You have now come into relation with the baby. And then by 1 month, it's about 16 times. So when we interfere with this process, especially in the newborn postpartum period, which is the first 6 weeks, we are shifting so many different mechanisms that we may not be able to bring them back together. And the simplest way of doing it is to keep the mother and baby together, follow the baby's cues, make sure the mother is well rested, she's well looked after, her emotional needs are met, she's mothered so that she can give that to her child as well. By about 6 weeks or 1 month or 6 weeks, 4 weeks, 6 weeks, the systems begin to settle. That's when you can introduce, there is a little bit of a tolerance window. As we keep going in age and coming together, the tolerance window increases. So at about 3 months, you could become the mother who pumps, goes to work, comes back, and the need is not changing so frequently. And well, fortunately, we have 6 months now to do that. So we can transition the baby from completely breast to maybe other food by the time we are ready to leave, or whatever system works for you. But it should be built on a system, on a well-established foundation of breastfeeding, the demand or the need and the response, rather than the demand and the supply, which sounds really weird. The need and the response. That's a very well-tuned mechanism, and then anything happens later will be able. There's a window of tolerance for you that you can practice all of that. A few more things that you must know about breast milk, and that will also help you understand why we are not encouraging too much interference right in the beginning. If it happens, it happens, but why it's important that we keep the mom and baby together, because how they are coming into attunement. And we call that the biodynamic nature of breastfeeding. Biodynamic means what? It means that the biology is adapting the mechanism and the mechanism is adapting the biology. And one of the simplest ways to understand is that we have a day and night cycle which is run by the sun. It's called the circadian rhythm. What does that mean? Mean that our body produces very specific hormones at specific times of the day. Would that affect the milk? Yes, it would. So daytime is about activity. So there are more activating hormones that promote activity. With brief periods of rest, so you might feel that your energy levels go up and then they go down and they go up and they go down, and it's autonomously run. You don't have to do anything. Whereas night is melatonin rich, which is sleep. So the quality of milk at night is more to do with what the body needs to do in the sleep, which is neurologically nurturing. Therefore, skipping a meal, especially in the early period, is actually becoming like a gap here. And so the milk quality is changing. It's different milk composition at night and day. That's one part. The second part is, and this is a story I got from Facebook, and the lady who's telling her story says that she fed her baby on the 11th of February at night and then expressed this milk. And then in the morning, she expressed on the 12th of February, she expressed this milk. And if you see, the color is different. And the way she's writing the story, she says that through the night, I realized my daughter had a bit of a cold. And food becomes medicine because the baby is telling the mother's body what they need. So not only in terms of nutrients, but in terms of antibodies, in terms of growth hormones, in terms of so many alive substances that are present in that moment and created specifically for the baby in that moment. And that is why also it is biodynamics, that the mother's biology is adapting and responding to the baby's need. Right here is the need and the response. So it is food and medicine and shifts according to the need of the baby. And this is, of course, something that people are very familiar with, fore milk and hind milk. Unfortunately, instead of giving the understanding that it needs to give, it's making people looking at time and saying, what time is fore milk and what time is hind milk? You can't say that because it's not time oriented. It's how the baby is sucking and what they are transferring. But to think of this, I'll give you a simple example. Think of having a meal, a fine dining experience. You usually start with a soup. A soup is watery, nutrition packed, and you have it quite quickly. And then you might have a salad after that. And then you might move on to a side dish or and then the main dish, which is very calorie rich. And then the final act would be a dessert. Think of your breast milk as that fine dining experience. It starts with a watery, nutrition-rich soup, followed by salad, then maybe some snacks, then a main dish, and then go on to become the dessert. This beginning is that watery, fortified skimmed milk. And this is the dessert, the fat-rich, creamy, full cream milk. And we don't know when it transitions. We don't know how it changes. But what we do know is that when we start to impose a schedule, a time on the baby's rhythm, we might break this natural flow. If you are switching breasts during a feed, after 10 minutes, your baby may have 2 soups and 2 salads and no dessert. Lots of peeing, but no weight gain. So we're going to say, put the baby to the breast, let the baby let go. If the baby is doing a complex mechanism of telling the mother what he needs or she needs, then I'm sure he knows or she knows when they are done. And they detach, and then you burp them or you hold them, and then it seems like they're looking for something more, and that might be a cup of coffee after the dessert, and that could be at a different restaurant, so you might shift the breast. Or if it's been a short feed, you could stay at that time. Don't look at the time, get the sense of it. Because 2 things will happen. When you get the sense of it, you will be tapping into your own instinct and intuition, which is really, really important, because that's how you're communicating with the baby. They are working purely on instinct. And secondly, the stress will go down, because numbers generally generate stress. So if you can just be with the baby and yourself, you will know what is enough and what is not enough. And of course, we're going to look at other things as well, which I will explain in a bit.
So, Divya, there's one question which is relevant to what we're talking about here.
Yeah.
She's saying many doctors suggest the newborn to be breastfed by waking them up every 2 hours, even during night. Is it a correct approach?
Okay. So I'm using this moment as a coffee break for everyone who wants to just stretch their legs, move around a little bit. But I'm going to answer that question because it needs a little bit of a detailed answer. Firstly, doctors prescribe everything like a medication. You have to take the medicine 2 hourly, 3 hourly, 6 hourly, but food is not like that. Secondly, you want to look at a broader picture of intake over 24 hours rather than every 2 hourly. Now, if you wake up a baby who's not hungry and try and breastfeed, because you've woken them up, they will suffer because that's their soothing mechanism. But will they truly take in the food that they need? So we've got to wait for hunger cues from the baby rather than the doctor. And the thirdly is you give yourself some time to look at the rhythm of the baby. So if you have a baby who's not interested in coming onto the breast, that isn't because, oh, let the baby find their own schedule. You want to first look at that, is this a healthy baby? Because your baby may need intervention if it's not fully healthy. So what we are looking for is what is their rhythm of wake and sleep, and are they getting at least 8 to 14 feeds in 24 hours? And then of course look at the parameters of what shows health. What they're taking in should result either with weight gain and growth or elimination. So are they putting on weight and are they eliminating well? And if you're seeing holistic patterns around it, like my baby drinks about 10 times a day, the night feeds are far apart, but the day they feed more, I will not wake them up again because they have a rhythm. But if you have a baby who just doesn't wake up and is sleeping for 6 hours, and then also you have to motivate them, then the question isn't about feeding them every 2 hours. The question also you should be asking, what's going on with this baby? Because his behavior is not very survival-like. This baby is not looking for food because food is essential for survival. What is he checking out to? Why is he sleeping so much? That's when you may have to wake him up often and feed him and pour food down his mouth. But you want to wait to come to that time when he wakes up and sleeps and asks for food. You want to look at that pattern. Once you have that pattern and the baby is growing and eliminating, then you don't have to do hourly scheduling. You don't have. So I wanted to give both sides of that picture. Does that answer the question, Tanvi? That makes sense.
Yes.
Okay. So I'm just going to encourage you to get up, stretch your legs. If you're pregnant, especially, get a drink of water. If you need to go to the bathroom, and we're going to take like a 4 or 5 minute break, and I'll be back. I'm right here, so you could type in your questions and whatever.
While we're talking about breastfeeding, somebody is asking, can I have 1 cup of coffee during breastfeeding? If yes, what's the best time to have it?
I can't say. How do you like your coffee? You can have a decaf. How strong do you like it? Do you like a dark roast or a medium or a light roast? Again, this is not something that you can pinpoint. So basically, we say that don't have is a blanket, but also how important is it for you and how do you want to have it? Educate yourself on what caffeine effect caffeine may have. You may also have a cup and see how your child responds to it in utero, and then say what feels okay for you. So you can enjoy the cup of coffee and feel guilty the rest of the day. Then that's not very good for the baby either. So trust that if you stay with what you feel, acknowledge your fears, your worries, and then choose. So you might do it twice a week. You might savor it and tell the baby that you're having coffee and that you really enjoy this coffee, and use it as a bonding opportunity and an enjoyable opportunity, not as a restriction and rebellion opportunity. Yeah, we have some questions about timing on. Wow. Okay, I'm just going to go through some of the questions that are like really significant. Tanvi, I can see your screen. Is that what your intention was?
Divya, so I put all the questions in one single sheet
Hmm.
so that we can just answer all.
We'll be able to bring it up towards the end.
Yeah.
Also, I might have a question for everybody to say that. How do you feel that some of your questions are being answered? Uh-oh.
No.
Uh-oh. You might want to send that to me.
Yeah, I'm doing that.
Yeah.
So, do you want me to bring up this sheet later at the end?
Yeah, we'll go through the sheet later.
Okay.
Do I shift back to my my screen?
Stop sharing. Now you can share yours.
It's how interesting that people are making connections between the baby's behavior and breastfeeding now. Otherwise, it was just the breastfeeding is separated from the rest of the baby. I love it that she's saying that he prefers one side and also sleeps on one side.
Divya, can we resume?
Yeah, I think so. Let's go ahead. Okay, so hopefully we're all here. And let's taking this forward. I want to give you some more practical tips now. So the easiest way for me to do it is to bring up a video that explains latch and breastfeeding, because seeing in this case leaves a bigger impact than my explaining it. And though I will take up some time to explain it as well.
Latching on is the term that describes how your baby attaches to your breast. Understanding and mastering the steps to latching on is the key to a successful, satisfying breastfeeding experience. In the next few minutes, you'll learn the steps to proper latching on. It's easy and a uniquely wonderful experience for you and your baby when you know how. First, get into a comfortable, slightly reclined position. You can use pillows for support. Elevate your feet to raise your lap slightly. Choose a position for your baby that works well for both of you. Here are 4 common ways to hold your baby during nursing. The cradle hold. Baby's head lies in the crook of your elbow or on your forearm. The cross cradle hold. Your arm goes around baby's back. You support baby's head with thumb and forefinger behind baby's ears. The clutch or football hold. Baby lies on his back between your side and your flexed arm. The sideline hold. You lie on your side facing baby. Experiment to find the position that works best for you and your baby. Whichever position you choose, your baby should be close to you with his mouth and nose facing your nipple and his hip, shoulder, and ear aligned. Support your breast by forming a C or a U with your thumb on one side and your fingers on the other. Be sure your fingers are far enough away from the areola that they don't get in the baby's way. Gently squeeze your breast, being certain that the squeeze is in line with your baby's mouth. When baby's mouth is wide open, bring baby to your breast. During a correct latch, baby will catch his lower lip on the breast and bring his upper lip over the top of the nipple, with his head tilted back. It's important baby latches on to as much breast tissue as possible, with his top and bottom lips flanged open like a fish. Most of what baby takes in comes from the part of the breast closest to his chin. In this technique, known as the asymmetric latch, the nipple is pointed toward the roof of baby's mouth. If latching on is done correctly, baby's chin will touch your breast and his head will be tilted back slightly. Baby's nose will almost touch your breast. Baby's lips will be flanged. That is, you should see both his upper and lower lips on your breast if you look closely. Baby's cheeks will be rounded and his temples will wiggle, and you'll be able to see his jaw working to help in swallowing the milk, with pauses for swallowing. When baby is done, he will let go of the breast or just fall asleep. It is also quite normal for babies to take a short break during feeding. It is normal in the first few days to experience discomfort while your baby is learning to latch, but breastfeeding shouldn't cause great pain. If you feel pain, don't be afraid to gently detach your baby by inserting a clean finger in the corner of his mouth. After you detach your baby, wait for an open, wide mouth and latch him on again. You could even try latching him in a different position. If pain persists or your nipples become sore or damaged, help is only a call or a click away. In most cases, just a little added guidance in how to latch on may be all you need.
So when we talk about help, again, don't make the mistake of thinking that your pediatrician can help you with lactation. That's not going to happen. Look for a person who is educated and this is their scope of work. So we are looking for, and because it's an unregulated space, so we have people who are lactation educators, which have a different level of education, counselors, and then there are consultants. Consultants are the ones who've actually studied breastfeeding, physiology, pathology, and can support you with problems that happen with breastfeeding. So shop around. Don't just accept anybody who gives advice on breastfeeding. Take it with a pinch of salt. Ask them to explain it to you. If it is the truth, it is universal. It's not, there is very little in the world that you cannot understand when being explained. So it's not like you're going to launch a rocket, but how the system works is fairly simple to understand. The calculations are different. So get to the right person when you're getting help. That's a really important thing. And don't wait to get help, because baby is changing. Their behavior is being set each day. Their experience is rich every day. So don't go through a long period of time of suffering before reaching out for help. Seek help as soon as you need it, and make sure that you get it from somebody who's compassionate, who mothers you, who gives you explanations, is patient with you and explains things to you. Basically, help should come to you in a way that empowers you to do it, not somebody else to do it for you, because that's not going to be a sustainable relationship. Okay, so in this particular segment, we talk about the different holds, and here are the different holds for you. The baby can go onto the breast in your arms, and if I were to use small doll to demonstrate it. Okay, so if the doll is in the crook of my arm, that's the cradle hold. I'm cradling the baby. But as soon as I change my hand under the head, it's cross cradle hold. This is a football hold, a sit-up hold. And the one that you see reclining back in the baby on top is called a biologically nurturing hold. That's the one you saw in the breast crawl. That's the one, even if the mom is a little bit lower and the baby's on top, say with a C-section, that's also possible. Basically, we want to bring the proximity of the baby's mouth to the mother's breast, and we want to support the neck, especially from a backward movement. Forward movement is not a problem. Babies are in the womb like this, so their heads going forward is not the problem. It's this stability that we are worried about. So that support is always at the neck from the back. Be careful to not touch the baby's head very harshly, because the bones are still moving apart, they're soft, and it feels like a lot of pressure. A lot of babies whose heads have been held hard, or especially being pulled out or used a vacuum or on, will cry a lot when you try and latch them, especially with the hand around the head. So make sure that the hand is well supported here. The neck is supported, the head gets direction, but not like a pressure on the head. That's just too much for babies. A lot of babies will cry, and I did see some of this. So their preferences on the breast, their positions of their head are telling you a story of their time in the womb and their birth process. And by being open to them, by acknowledging it, and by also offering them gentle contact, you might resolve some of the patterns that they hold in their body. Now, what I'm talking of now, I've moved out of the realm of what is purely breastfeeding, breast and baby, to the realm of craniosacral work, where we're treating the baby's body for the story that they are carrying. Fortunately for us, babies have very tiny stories. They're not very attached to their stories. They don't have patterns that have been repeated over and over. So you can resolve them very easily. If you don't have a therapist at hand, a body worker on hand, the best therapy for your baby is skin to skin with a mother who's deeply relaxed and feeling love for her child. That is the best way to resolve some of the patterns that the baby carries, is that the mother is relaxed. There's no limitation on time. The mother and baby are skin to skin. He's soaking, especially areas that his preferences are, saying, oh, what's going on here with you? What are you trying to tell me? And you'll find that resolution will happen very quickly. It is because we are forcing, and even the language we use about extraction and forcing is kind of a burden on that poor baby to carry, because he's been pushed into something that is not come easily or naturally to them. But by saying, okay, let me help you do that, immediately the response will change, and you'll find that difference in your children. So here are the different kinds of holds. As they get a little older and the head can be supported, they can be actually sitting up, especially for babies who are, who need to agassi or things like that. That might be helpful, and they can come on and come off at will, and then you can just support that process. The key mechanisms of a good latch, and I will emphasize them over and over in different ways in this section, because if you've got a good latch, Nothing else is needed. That's it. That's it. That's the start and end of breastfeeding. So here's the first point. The first point is that the nipple is pointing towards the nose, not towards the mouth. Can you see that? As the baby feels the nipple at, at the frenum or at the nose, the rooting reflex will say, lift the head, open the mouth. And now it's well aligned, but it's aligned in a position that will touch his palate, because that's what it's going to do. When babies' palates are touched, they start suckling. So if you have one of those babies who have to be taught to suckle, clean your hands and put the pad of your little finger in their mouth and just touch their soft palate gently. Very soon you will find the suction will come. And that's one of the way of reorienting them back to sucking. And when they are really distressed and they are not calming down, letting them suck on your finger is helping them soothe again. So you can use their oral pathway in many different ways to promote, to soothe them and to bring them back to breastfeeding. So if you see the tip goes into the mouth, the baby's mouth is wide open. Look at that angle here. And then this baby is brought to the breast. See that motion? You're not pushing the breast to the baby or bringing the baby to the breast. I will show it to you in a smooth motion in a moment. And as it goes in, the nipple will elongate. Now, for people who have had some issues with nipple, we'd like to think that what happened before we became aware of, flat nipples and all. How did people breastfeed? Because majority of children were breastfed. Now, as you are going through spontaneous labor, your body is softened, at least the ligaments are softened by relaxin and estrogen, and all of these hormones are actually softening the ligaments in the body so that it can open up for the baby. There is a tissue or a ligament behind the nipple which elongates when you stimulate it. And with that elongation, the nipple protrudes forward. And for some, that may be a little restricted or tight, and for others, it may actually contract on touch and make it inverted. When there is relaxin in the body, right in the beginning, right after birth, and the baby comes out of the breast and sucks hard, because of relaxin, that tissue elongates. So a lot of these issues may get resolved if you are having a spontaneous birth and the babies come onto the breast, and then the baby just forms the nipple, or over a period of time, suction and pulling the nipple will form it. But as you delay it, you find that there will be more trouble. In terms of breastfeeding, a flat nipple doesn't affect, but the latch it does affect if the baby is not able to get a mouthful around the nipple and it slips out. It does affect. And if that's one of the cases, you might seek specific help, because not everybody has the same issues with flat or inverted nipples. And so you might want to see a consultant about that. And then that nipple is actually elongated in the baby's mouth, touching the palate, encouraging the sucking behavior, and the baby will suck. As the baby transfers milk, the mouth fills up, he will coordinate the swallowing, the breathing, and there's a pause. And then we'll start to suck again motivatedly without you touching any of these. Because if you have to do this and make him suck, then your question should not be, is my milk enough? You should say, why is the baby not motivated to suck? And the only reason for that is that it's a bad latch and he's not getting milk, or he's full. But this cannot elicit breastfeeding. It can elicit mouth movement because this is irritating and the baby sucks to soothe and then stops again. But if the baby is hungry and the milk is available, we don't have to tell the baby to feed. Like any other living thing, we don't have to teach them to take nutrition to survive. That's not okay. Now imagine yourself eating, like you're eating something. Do you eat continuously or do you pause between the swallowing? And so give the baby the same feeding behavior as you would have for yourself. Here's a practical guide. First step to see is the mouth open narrow. There's a difference. This angle is 120. Then we see that the nipple is actually in line with the nose or eyes so that the baby may rotate or tilt his head backwards. As he tilts his head backward, the nose becomes clear, the chin comes forward. Now, newborns have very recessed lower jaws. So this will bring their jaw into contact with the breast. Then the mouth is wide open. Special note for moms who hold their breast. Imagine now that you're eating a burger. It's a Big Mac. You have it in your hand and this is your mouth. What do you want to do to put it in your mouth? Off note, look at the way my lips are and the way my fingers are. So my lips are horizontal and my fingers are horizontal. Now I'm going to put this baby in a sideline position at the breast. Are the lips horizontal or vertical? And therefore your hold on the breast is also U-shaped or from top. Generally, when you hold your breast from top, you can't see the baby, but when you hold it from the bottom, you'll be able to latch the baby well. And so that's the part about keeping your fingers in line with the breast. And these are the signs of your correct latch: flanged lips, lower chin is going in, nose is free, and the baby is showing motivated suck, swallow, pause, and start again. And the mother feels no pain. These are the thumb rules. So tummy to mummy. Not like this. Nobody can swallow with their neck turned on the side. Right? Then let me go back forth. Tummy to mummy, nose to nipple. The baby will lift their head, open their mouth. You do a burger squish in the direction of the baby's mouth and bring the baby onto the breast. So tummy to mummy, nose to nipple, burger squish, and baby comes to the breast. Breast does not go to the baby. If your back is out of alignment, you will feel pain, and over a period of time, it will become a back pain, and the baby will become fussy because pain also elicits the same anxious response in the body as anxiety does. Okay, this section, any questions, put them in. And then I'm going to show you two wonderful videos about to know, is my baby hungry, and when to eat. So a lot of people think that when the baby cries, we feed him. But we know now that crying is the late cue of hunger. Crying is a point where the baby is saying, Dad, you're not listening to me. So we are waiting for cues, or we are looking for cues that tell us that the baby is ready to feed without making the baby cry. We don't want to teach our children that only when you cry, you get something. That will make them really cry babies in life.
So, Divya, for the previous section,
There's lots of instinctive.
now.
Yeah, Tanvi.
Should we take up the questions now for the previous part?
So we're just going to very quickly complete this, and I'm going to take the questions on a roll. But you'll also find that I will refer back to these parts to answer those questions. So I'm going to build that picture for you so that you can see all the parts connected.
Sure.
Would that be okay?
Yes, absolutely.
Okay, let's go. So hunger cues.
Behaviors that babies use to tell you they're hungry long before they cry. This baby here is not hungry. You can tell because this whole body is relaxed. She's got her eyes wide open, mouth is quiet and not moving. This baby just wants you to talk to her and engage with her. But as a baby starts to get more active, that tells you that he needs something, and usually he needs food. Notice all the mouth movements here, lip smacking, turning the head side to side. Hungry babies also like to suck, and they will try to suck on pretty much anything that they can reach. Really, on anything they can reach. They may not have figured out yet exactly where the food comes from, but they know they need to latch on and suck to get it. Notice this little one, turning his head from side to side, trying to figure out where the milk comes from. That's called the rooting reflex, and we can also test for that with our finger. So notice here, the baby turns toward it and tries to latch on. As babies get hungrier, they'll often try to put themselves into the right position to nurse, and they'll dive for the nipple. They may dive for the nipple on almost anyone who's holding them.
Lydia, what are you doing?
Yeah.
Lydia, that's not gonna work.
This next baby is sucking on its hand and it's starting to fuss. We kind of missed the early hunger cues and he's starting to escalate up now.
So we don't wait for hunger cues to reach this. This is available everywhere. This is a feeding cue chart. Early cues are stirring, opening mouth, turning head side to side. Then mid cues are now I'm getting really hungry. But remember, for babies, because they're really tiny, they can go from hungry to very hungry to blood sugar dropping very quickly. And so stretching, increasing movements, hand to mouth, crying, lots of movement, and color turning red when they're like, come on, feed me. When they're in the late queue, you have to first soothe them before you can go back to feeding them. And so when we are looking at babies' early cues, we are also, because we're paying attention to babies, because we're bonded, because we're attuned, we can start to look at their rhythms very quickly. In the first 2 weeks, you'll be able to understand your baby's rhythm if you spend that time together. And you'll kind of know by looking at them what they're going to do. They have a specific phase of peeing, specific phase of pooping. You also know, in the morning he feeds more often. In the evening, he's a little bit more cranky. The night feeds are like this. So you'll be able to predict these patterns. And then you'll be able to adapt to them. And as you meet them over and over and over again, you will find that your babies will start to get a little bit more tolerance levels. Like they can cry and they can patiently wait because in their head, they now know that you're going to respond. That would be the basis of their relationship with you. That's the basis of trust in the world. That leads to a lot more developmental milestones in terms of psychology and emotion than just breastfeeding. Breast milk can. I'm giving my baby the best nutrition, breast milk, which again, I'd say not true in early times because the need is changing so quickly that expressed breast milk does not truly meet what that baby is in this moment. Here on the contrast are full cues.
In this video, you'll see clips of babies who just finished eating. You notice at the end of the feeding, they're calm, quiet, relaxed. They often look kind of milk drunk. These are babies who are satisfied and well fed. If you contrast this to the hunger cues, there's a big difference. You'll notice with hunger cues, there's lots of movement, lots of mouth movement, making noises, sucking on things, turning their heads side to side. These babies are no longer showing any of those cues. They're relaxed, they're hanging out. After nursing, but when they're not asleep, they tend to look like this. This tells you that baby has gotten plenty of milk. You'll also be checking their diaper counts and weight gain, but you can rest assured, if they look like this at the end of the feed, things are going well.
Yeah, so we said that how do we see the baby getting enough because we can't measure the breast. Now, for those of us who think that if we express, we can measure that, the mechanism changes. When the mechanism changes, the transference changes. So by pumping, you may not get the yield that your baby's mouth and love would elicit from you. So we're not going to get into the number and for other reasons as well. But here's a very simple way of understanding it. Think of the first 5 days of baby's life as a transition period to get to know this world and set up the kitchen or the food counter, or whatever you want to call it. So on day 1, you have colostrum, and the baby needs about 5 to 7 ml per feed, and you feed on demand, which is 8 to 12 times in 24 hours, and you will get 1 urine, not wet diaper. It says diaper, but I want to reframe it to urine. 1 urine and 1 or 2 stools, which are going to be greenish, black, tarry meconium. So the system is cleansing, and colostrum is offering the baby not just nutrition at that time, but a rich plethora of antibodies. It's offering food for the digestive bacteria in the baby's gut. It's laxative in nature, so it's cleansing and setting the scene for digestion soon to come. On day 2, the urine will grow to 2. The poop will also grow because we're still cleansing out and still it's green, tarry or meconium. By day 3, for majority of women, milk will come in. So now the milk is not that sticky colostrum, but now it's become a little bit more liquidy or thin, watery. And the urine will go to 3, this day 3. And when I say day 3, it's 24-hour cycle. 3 urine. And now the poop is turning to about brown or green and then to brown or yellow. And all the way up to day 5, where there are about 5 urine. And now the poop is yellow. Up until now, this baby has lost weight, about 5 to 7% of their birth weight, and that is normal. That is acceptable. Because in setting the systems, this is what we have lost. Now by day 5, because the engorgement came on day 3 and because you were frequently feeding, your body has got enough cues, the milk supply has also now settled. So all the things that you feel in engorgement, which is heaviness of breast, lumpiness, all of that is gone. For a moment, you might think that, oh, maybe I'm not making enough milk, but you're making just right for the baby now. From day 6, we start to look at 8 to 10 wet nappies or urine, 8 to 10. So we are basically saying that there is so much more hydration is needed. Now the system is set and working. You'll have 4 plus poop, but the poop is going to be yellow seedy, mustard seed kind. It's not too much, but it might happen after every meal. And the baby will put on 25 to 30 grams per day, which means in the next coming week or so, the baby will put on his birth weight or her birth weight back. At 2 weeks, for sure, the baby should be birth weight. So nothing lost, nothing gained. Systems have been set. And thereafter, it's 25 to 30 grams a day. So anything between 750 grams to 900 grams a month. And if that is happening, you've seen through the first 6 weeks, so the 2 weeks of transition, and then the first 4 weeks, which is 1 month, if your baby is passing enough urine, which is well hydrated, there's enough poop, and that might go up and down because as the system starts to settle, you may have days of no poop and then lots of poop after every meal. That's not the worry, but there is an elimination and there is weight gain. Then we don't worry about how much and how long and how many feed. We are making enough, baby's getting enough. At about 3 weeks, at about 6 weeks, they have a growth spot. So think of it like if your baby was 3 kilos and is now 3.5, that's 1/6 of the weight growth. That would mean extra calories, both in quantity as well. How does the baby tell the mother's body to make more? By being fussy and feeding often. More is the need, more is the response. Within 3 days, all these different paradigms settle, whether it's engorgement, whether it's a growth spurt. If you respond to it, in 72 hours, your body will adjust to it. Simple. If you intervene at that time and bring in formula, that's when instead of making more, you will now make less. So this understanding, again, why is this an orientation? This understanding, this knowing will help you tide over that tough time. So what could you do if the baby's having a growth spurt? You crawl into bed, put the baby close to you, be well regulated, have good help and support around you, and feed on demand. And soon enough, the baby will settle. If after 3 days the baby is not settling, we can question what's going on, which is really rare. But most babies will settle in that much time. And then they'll start to show a pattern because as their brain grows, they start to come into this world with their own patterns. We start to read those patterns and coordinate with those patterns. And that would be a great routine for you to have. So not a schedule, but a routine. And so this gives you like, is the baby getting enough? And that should answer your questions to a fair degree. Okay, so we're going to ask questions that might bring up other problems which may be common. Now we're going to take them here. So I'm going to stop my share here. Oh, one important part that I did want to say is when I talk about 8 to 14 feed, I'd like you to do a very quick count in your mind. How many times do you eat or drink in one day? Just to put it in perspective. And if you could just put it in the chat box, that number. So how many times do you eat a meal, a snack, a beverage, tea, coffee, and glasses of water. Add that up and put it down, please. How many glasses of water? Add that as well. So you should be having at least 6 glasses. Yeah. So we are now hearing that you have something between 10 to 12 times you have something. And that helps us understand why the baby also needs frequent feeding. And not all feeds are equally long and cannot be long. Some of them may be water, a beverage, a snack, or a meal. And so there'll be some long meals, there'll be some short feeds, some maybe just wanting to have a sip of water or a glass of water. And you've got to start treating it like that rather than measured and scheduled. Also think, do you always eat and drink when you're hungry and thirsty, or do you do it because you're bored, you're lonely, your social occasions? So baby may have all those needs as well, but is seeking all that comfort at the breast. In any feed time, 10% of sucking that the baby does is non-nutritive suck, which means they're moving their mouth and getting that sensation without actually eliciting milk. And non-nutritive sucking is a soothing mechanism. So babies who get uninterrupted, their needs are, let me say, acknowledged. When we let babies do what they want to do and we respect that, we're basically telling them that we trust them, that they are capable, that their needs matter to us, that they are important. And when they get that non-nutritive sucking, they feel safer, they feel better, they feel... So a lot of sucking that babies do is also non-nutritive because they need that as a developmental thing. And then they also self-soothe because they're anxious. So our job as parents is to eliminate things that complicate it or make them need more sucking and offer them adequate sucking so that they feel and they grow from it, both food-wise and developmental-wise. And breastfeeding contains all of that at one source. Okay. All right. Now I'm good for questions.
The first 3 questions have been answered. The 4th question is, in some hospitals, without mother's knowledge, they're giving formula instead of colostrum. How to convince them?
So no, you're right. Your right says, and that is the IMS Act of 1992 and then modified later. It says that nobody can give your baby any formula or anything without your explicit permission. They cannot advertise. So many and rooming in. They can't take your baby away from you. So make sure that you represent yourself courteously but confidently about your breastfeeding. And own it, saying, I am going to breastfeed, so I would prefer you to leave the baby with me and provide me with resources as a hospital, because it's a consumer arrangement to support my breastfeeding. So ask for it. When we allow them to take our babies away from us, we are giving the baby a separation anxiety, which is a real thing, but we're also giving them access to our child. So by being really confident and, well, not aggressive, but assertive and courteous, you ask for it. It is your right.
Right. How can mother identify tongue tie?
Okay, so I'm not saying that you are identifying a tongue tie, because that needs, again, see, it's a problem. So it needs somebody whose scope of work or as education is included in it. But here's your way of looking at it. If you have managed to get a good latch, the baby, it's following all the criteria of the mouth on and everything there. If it's managed to get a good latch and it still hurts in breastfeeding, we would look at an oral issue. That issue could be a frenum attachment, a tongue tie attachment, a palate issue, some issue in the mouth that is not allowing the biomechanics of sucking to take place effectively. It could also be low weight, frequent feeding, because the baby is not able to do the work efficiently because of some hindrance in the mouth. And that's when it should be evaluated. It should be evaluated by a consultant who understands tongue tie and not a pediatrician. So a lot of assessments are done by either dentists who are now educating themselves on the oral and breastfeeding issues, or lactation consultants. Not all lactation consultants are looking at tongue ties. Majority of pediatricians will say tongue tie does not affect breastfeeding, so their knowledge is limited. So you find, and the revisions and other things are now being done by dentists. So you look or work with a consultant who specializes or understands tongue tie, and they can evaluate. But for you to get a cue that I need help would be either lack of staying long on the breast, very, very long on the breast, pain at the breast, and not putting, despite of sucking, not putting on enough weight, which means effort is eliciting very little response. So we're looking at it in a very common sense way. If this picture is not making sense, I need help. But I put the baby to breast for 2 hours, baby doing nothing, that's not working. I do this 20 times, then the baby's not sucking. And despite of doing everything right, if the weight gain is not there or there is pain on the breast, that's an oral issue and that might need to be evaluated. So that's one of the ways of looking at it.
Right. The other question is, at what are the constraints that a postpartum lady don't have milk to feed?
There is no such thing they don't have milk to feed, because we've already looked at it that the mechanism is designed for abundance. And if it is, so the only person who will not have milk to feed is somebody who has a glandular issue or has had a breast surgery and the ducts have been cut. Everybody else will make milk. They may feel they don't have milk because they're highly anxious. So in that case, you can either use supplemental, or you can also express, if that works for you, and use a supplemental nursing system to keep bringing the baby to the breast. Because over a period of time, this proximity of the mother and baby and the love between them will resolve many of your issues. So, I mean, that's how I understood the question. So I hope that helps.
Also, she's asking what can be the reasons for low milk supply. So it could be stress, or
it could be a hormonal jump to begin with, that you had an induction before the baby was ready to come. And then add to that the separation, and they added formula. So it could be very layered. And the answer is to bring the baby to the breast as often as possible. And if you still feel that the baby is not gaining weight and needs to be supplemented, look for a way to make that supplemental system at home. It's very simple to make. Maybe at the end of the session, I might find the tools to make it. I'm not sure if I have them here. And then the baby can be fed at the breast by whatever means, so that that interaction between the mother body and the baby is continuous, and then the milk supply will rise. Right. So you can express, you can do some interventions. You can start to express on a routine so that more and more is removed, and then bring the baby. So now you've staggered the system. So the stimulus to the breast and the removal may be 2 different jobs till your milk supply rises and they can become one again. The idea is to integrate that.
Right. The next question is there any specific food group that one should be specifically consumed for nutrients to the baby through breastfeeding?
All food groups that give you nutrition. Remember, your body is the storehouse, it's the warehouse. And the delivery to the baby will be done as they place the order. So good healthy food, which is easy to digest, so that your body is not expending its resources digesting heavy food. Postpartum diets are all about that. High nutrition, easy to digest food, and see what your lifestyle is. There are things that help promote breastfeeding. I don't think there's like a science behind it, but basically these are things that support your body's assimilation, digestion, and therefore support breastfeeding. Think of it as an inverter. Your body has a power inverter, and it can power 3 lights and 3 fans. If you try and put on 5 lights, everything's voltage will dim. So look at what your lights and fans are in postpartum period. You are recovering, postpartum recovery is there, lactation is there, your heart, lungs, and brain has to work, and then other things that your body needs to do. So if you're exercising a lot, then you're wasting calories there, and then where will you take it from? So your digestion will get depressed, and that's why you have more chances of indigestion. Indigestion means not good nutritional intake. Even though you're eating well, you're not able to assimilate it because your body doesn't have the resources. So basically, we are optimizing body resources to bring in these new functions. By 6 weeks, most of postpartum repair is done. We can free up some energy from there and put it to digestion and eat different kinds of food. So spices, heavy food, oily food, Avoid. Freshly cooked, not even raw food. Raw food also takes a lot of effort in digesting. Freshly cooked food, which is light, nutritious, and easy on the stomach.
Some people say that we should protrude the nipple to help in breastfeeding. Should we? And should we wash our breasts every time before feeding?
So Montgomery tubercles are producing antiseptic lubricating fluid that smells like the amniotic fluid for the baby. So that should take care of your question about washing. When you wash, see the perception. When you wash, how do you know the quality of water is really good and the soap is good? You know, I see in hospitals, people have those cottons that they've dipped in sterile water. How did you know the sterility of that cotton? How can you be 100% sure? Whereas your own body produces things to make it antiseptic and attractive to the baby and lubricating, so it won't dry up if you don't clean it too much. So this obsession with outside sources cleaning you up is also an idea that we are polluted and not good enough. That's not true. Unless there is a problem like the baby has an infection or you have an infection, then yes, treat it. So don't interfere if things are going well, and definitely get help if you do need it. That's one. And you don't really need to protrude the nipple, because you'll find that your nipple has a very unique quality. In cold and other stimulus, it actually gets erect by itself. If it doesn't, then it's called a flat nipple, or if it turns inwards, an inverted nipple, but it will get. So what is there to protrude? There is no reason to protrude it. Just bringing the baby and stimulating here will make it erect, and the baby's mouth is not coming on the nipple. If it comes on the nipple, that's when you'll get the cracked and sore nipples. So the latch means that the jaw of the baby is behind the nipple on the areola. Baby is holding it from here. So human lactation is not like cows. You're not doing this to bring out milk. Try, if you are a lactating mother, try it. Make a C in U of your hand, put it wide from the nipple. Push the nipple into the breast, inward, towards the chest, and bring your fingers together and release. You don't have to squish the milk out of you. You have to create a rhythm like the baby's mouth and jaw does. So press, compress, relax, press, compress, relax, press. And the more the rhythmic and easy it is, the more the milk will flow. You don't have to squish it out. And that's basic misunderstanding we have about human lactation, is that we think that we have to squish the milk out. We don't. So we don't have to do all of that. If the jaw comes on the right place, the tongue and the jaw work together. That's why the tongue tie restricts that movement. So the tongue and the jaw come together. The lip tie stops the seal, the vacuum seal from being formed, and air is pulled in. That takes away the suction. So there are many things that contribute to a good suckle, but mostly we don't need to know all of them. We just have to get the latch right. The baby knows what to do. Like that.
Why they're not allowing breastfeeding immediately after C-sec in some hospitals, even if we suggest?
I don't know, but I have a few theories on it, and these are personal, so I will own them. Firstly, I think that it takes a lot of effort. First step is education. Most people don't think it's possible. They don't want the baby. They're treating the mother. C-section is the only surgery in which I feel a room full of people around a woman who's just had a surgery. So you need privacy. Secondly, it needs support. So you need a nurse or a family member who's committed as you are to that breastfeeding, because the mother is lying on her back. And so the holding of the head, the supporting, it's an effort. And I think that is missing. And I don't know why hospitals don't do it, because they think they might have to give resources. And it's easier for them to collect the children in one place, have one nurse in charge, and feed them on a schedule. It's just easier.
Right. What if a baby is premature as breathing coordination is yet to be developed?
So premature doesn't truly come with breathing issues. It truly does not come under the purview of a normal breastfeeding baby. But breast milk can be offered, and it will come. For a mother to express that early, she will need a lot of commitment and love for her child, and a surrounding that is very respectful of her breasts, that treats her body like a temple. Because the minute she gets anxious and she feels a little constrained, the colostrum, which is so tiny, will not come. And then you can start feeding the baby. Now, depending on what is the level of difficulty of breathing, maybe we don't want them to suck that hard. We don't want them to make that extra effort because they're preemies. We want to give them high content milk early so that we build their resources, they can come back to breastfeeding. So you can see, we can do finger sucking as well. Use the supplemental nursing system, place the tube with your finger and bring the finger in, the baby actually sucks from it, and then pour a little bit. So we're trying to manage their effort as much as possible under the medical realm, keeping the experience of this movement and straddling both worlds together. So for a premature baby, that would be one of the considerations, and lot of candle care, lot of being with the mother. Because if the baby is premature, their brains can get quite disorganized by being away from their mothers. A lot of the development of our bodies happen in our mother's womb in relation to the mother. So a lot of her presence is important. You might find yourself in many hours doing skin to skin in the nursery, and you don't have to do the job. Your partner can also do the job. And so both of you are bonding, reassuring, keeping the baby, giving him the environment development. Development will happen better if the baby feels safe, and then giving some expressed breast milk. Premature babies' milk is different than full term. It's very high protein, so it's very different.
Right. So next question is, I'm at 22 days postpartum, had vaginal birth at 37th week without medical interventions, as I'm a first-time mom and I had more blood loss. My midwife's full attention was on me after birth, so breast crawl was not established. My son was not latching deep. Now, how can I help him to deep latch?
So baby moon. So for most people, to my utter surprise, baby moon's taking a leave of a holiday with their partners during pregnancy. But as far as I'm concerned, a baby moon is what you do with your honey on a honeymoon when the baby's here. So which means you crawl into bed, skin to skin with your baby, and stay as long as, and enjoy your days with the baby, watching him or her, or following their cues and allowing them to be close to you, reassuring them, singing to them, and following that cue and encouraging them. So that whatever, so, a lot of blood loss for you is quite a trauma to your body. It is one of those survival traumas. And so taking the time yourself as well to metabolize it, to process it, to integrate it, to be kind to yourself and not put so much pressure. And then, leaving the baby close so that that response is elicited, and see if the baby is encouraged to get a deeper latch. A lot of time babies don't get deeper latches because they can't open their jaws wide. And that's because they also feel that stress. And then as we let them release and integrate that experience, their mouth might open wider. That might help. That's one of the things. Or you can do some finger sucking, support the baby or encourage, find ways to make the baby make the mouth open wider, bring the baby in closer to the breast. These are some of the things you can try and see if that works for you.
When we talk of uninterrupted breastfeed, should the baby not even be clean before first skin-to-skin contact?
Okay, so the word clean, it's again, I'm highlighting the language we have used around babies. The baby is factory clean when they come out. They're just wet, so pat dry and no separation. That's what we're talking about, uninterrupted.
Right.
When baby comes onto you, the baby is wet and there's vernix, there's that cheesy material on top, the white, depending on what age they are. It may be all over or it may be just in the crevices. Now, the wet needs to be pat dried because the baby will lose heat. So we pat the baby dry, maybe lift it a little bit, wipe the mother, and then pat the baby and put the baby right back. But we're never taking the baby away because the cord is still connected right in the beginning. And then we let the mother and baby discover each other, and even the father to put the hand in under the warm blanket and stroke the baby gently, firmly, not tickling, but gently. And that vernix will then begin to spread and make a layer of protection on the baby because it is waterproof. So the idea is that when the baby is in contact with the mother, the skin bacteria or the microbiome of the mother becomes a part of the baby's microbiome. It kind of envelops. And then with that vernix on top, we seal it because that's home bacteria, and then the outside bacteria, the good bacteria and not so good bacteria. That's the idea.
Right. So when can we start giving water to the baby? From which month?
It's not month oriented, so we don't talk in terms of water. The baby doesn't need hydration per se, because remember the first part of the milk is soupy. It's hydrating in nature. When we start with solid food or we start supplementing the food, and it says 6 months, but I don't like to talk of it 6 months. I'd like you to look at the baby's development. If your baby can sit up and hold the core muscles to have an upright position, they may be ready for solid food. You will also watch the baby's cues of reaching out and trying to eat and enjoying food. That's when you start. When you start giving them solid food, that's when you may introduce water or soup or whatever you want, because it's a part of outside feeding. But breast milk itself is hydrating enough so the baby doesn't need any extra water.
What happens to a toddler when he still breastfeeds while his mom is in second trimester? Because of progesterone, does it impact?
Not really. There are other mechanisms at play because the baby is also eliciting. So you can do tandem feeding. You can feed a toddler and a newborn. And now it makes sense because when the toddler's mouth is at the breast, your milk is modified or customized to the toddler. When the newborn comes, it's customized to the newborn. But no. And if the baby is a toddler, then he's also having a lot more other food. So it's not the full demand is not on the mother's milk. So continue to breastfeed, it's fine.
Right. My boy projectile, after he gets feed in the right breast, I tried engorging the milk and tried this, it's still the same. I don't have symptoms of fever or anything.
So a lot of children throw up projectile and only from the right breast.
Yeah.
So maybe the right breast flows faster and he chokes on it. So you'd say you make a cigarette hold and so you'll feel the letdown reflex because oxytocin doesn't come in one go. Prolactin is always present. So it starts when the mouth is stimulated and then stays till about the feed is finished, about an hour after that. But oxytocin comes in pulses, in waves. So you'll feel like there's a milk letdown and then again. So in the letdowns, if you bring your fingers and press on that, slowing maybe the baby will feel more comfortable drinking it. If the baby was throwing up or spitting up after every feed, then we would say the issues with the baby. But here, it's not every feed. So each side, it's one side. So maybe that's happening. I mean, it's just an educated guess on my part.
Right. I'm in my second pregnancy, having full trust on exclusive breastfeeding, but during hospital stay, they are asking moms to give formula as top up for first 2 days alone because milk supply will not be established. How to avoid it?
By telling them that my colostrum is fully there. See, this is a negotiation you'll have to do at every level because we've understood that neither the babies need that extra food, nor do moms make it. So yes, the milk is not there. It's the truth. But it doesn't mean that nothing is there. Colostrum is still there. And you're in your second pregnancy. So you can tell them, I fed my first one. There was no problem. Do you have a reason why you see a problem? Ask them for a small explanation. They'll back off very quickly.
So,
and you have experience on your side.
So you're saying through the first 2 days, only colostrum is what is needed for the baby?
Yeah, the baby only needs colostrum in the first 2 days. Remember, we said that you can see throughout development that the mother's body and the baby's body are actually quite attuned. So as the baby's need will rise, the mother's body will make milk. Now, there may be a little bit of a lag because of whatever intervention may have been done, but it will catch up. So because if we're going to introduce heavy formula in the beginning, the baby's just going to sleep and very little stimulation will happen on the bed. So it's not going to be a zero. It's going to be negative. We want to avoid that. And then only if needed, see, we should look at intervention and interfering with things and needing help only when needed. Not when you start to look at these paradigms as a general rule, you're also literally saying that my body and my life is I'm not capable of it. And therefore, please, I need help all the time. That's not true. But it is, on the other hand, also true that everybody needs some help sometimes. It may or may not be you. So don't use it as a blanket. Yeah, we need formula. You don't. So let's assess. You can say that I've already fed. I never had a problem with my first one. Do you see a reason? Let them explain. Because I find it very strange that we just accept this narrative about our incompetency without question.
Right. Can you please speak about how long you'd recommend breastfeeding for babies? I understand it is a supply and demand equation as long as they'd like it, but can you give us an idea about timelines?
Now that's a tough one because only the baby and you can decide the timeline. And why I put both parties as equally important is because breastfeeding is not about transference of milk. It's about a human relationship or an early education program, if you please. So we'd say 6 months, and I've already broken that down to the middle of the first year is exclusive breastfeeding. Think about what breastfeeding is offering the baby and you. Chance to connect, immunity, bonding, a relationship, whatever it is. And how far does that go? Also practically think when by 1 year, if your baby is eating food off the table, how many times are you breastfeeding? And how does that fit into your life and how do you feel about that? And then see where you want to put the limit. But as far as research goes, we say that primates, which are our cousins, feed their children till the first molar, and that we can say for human babies could be 6 years or 7 years. So you can feed that long and nobody should stop you. There could be two possibilities. A, that the baby self-feeds and stops feeding and it's led by the baby. And the other is that while the baby still wants, the mother is finding it difficult. So we are trying to balance a happy, healthy mother with a happy, healthy baby. A mother who's breastfeeding but is resentful, angry, and is going through something is of no benefit to the baby at all because it's an unavailable mother now. So how do you strike that and find a balance for you? You decide. There is no judgment on how long you feed. It's how you experience it.
Okay. So next question we've almost covered in the previous.
But there's another part to that. For how many years after the baby is born, the mother lactates? So as long there's a child to her breast, which means her own child is 10 years old, but she decides to adopt one or decides to feed her sister-in-law's child because the sister-in-law is having some problems. You will continue to make milk. You will continue to make milk till your body is responding to a need of a child and the pathway is the mouth and the transference. There is no time limit. If you are a lactating mother and you've done it once, you can start to lactate again and feed an adopted child. If you are a mother of an adopted child or you have a surrogate, you can stimulate the breast. There are the Newman-Goldbach protocols that can induce lactation. So pregnancy prepares your body for lactation, but pregnancy is not why you lactate. You continue to lactate if you have the mother. I did want to bring that in.
Beautiful. What does it mean if baby sucks thumb immediately after feeding for 10 minutes from both the breast? People say that baby is still hungry and milk was not enough, but I could see milk.
And the answer is in the 10 minutes. Why are we assuming that the baby is being fed well because it's 10 minutes on both breasts? So he's had soup and salad, no continuity of experience. In fact, when he was getting into the juicy part of the food, you took him off and put him on the other side. Put yourself in the baby's booties and imagine what it may feel for them. Remember, because nature hasn't designed mechanisms that are to be supported from outside, like look at the time and schedule. They are inborn clocks for these things. So if your rhythm is disturbed for whatever reason, how would it feel to you? You are the baby, be the baby and see. You'll realize the answer. So some of his sucking may be because of his frustration. Some of it could be hunger, but not because you don't have milk, because you can have 6 soups and still get hungry. So think of it in those terms of what we've collected over the last 2 years.
Right. After the feeding baby, how to feed when the mother has severe nipple cracks?
Go after the nipple cracks first. So severe nipple cracks have developed because of a bad latch. First, prevention is better than cure. Make sure that when you feed the baby, if your discomfort is more than 30 seconds, de-latch in and improve the latch. You will not get sore nipples. That's it.
Right. So
And if you do have sore nipples and you have a good latch, it will not hurt you. And then the nipple will take its time to heal, which means that touching, the latching and may be painful, but the feeding itself will not be.
So I think the next question we've already covered in previous.
Yeah, also see the word extraction.
Yeah.
If we start to look at a gentler language, a more instinctive, in-body capability assessing language, then we won't feel so fearful.
What should be the steps after women see low secretion or low milk, like diet or anything else?
How do you measure low secretion and low milk? How do you see that? How do you evaluate it? You can't measure it.
Maybe
So if you're seeing a lack in the baby's urine, then feed more frequently, which means he needs more watery stuff. If you're seeing the weight gain on, then feed longer on each breast. If your baby is lethargic, question into that. What is it that is he unwell? Is he stressed? Skin to skin, keeping the mother happy. Eating foods that may support breastfeeding by, say, better digestion. So ginger, is one of the things how we see it. But they also aid digestion. It stimulates parts of your body that promote breastfeeding, but there's no direct link that if you have this, you will get this. It's not like that. But how do you evaluate it? First, let's see that. Your baby's not sleeping for 6 hours is not low milk supply at all. And if you're measuring it by pumping, that's not a true value of how much you're making. Because the mechanism of the pump versus the mechanism of the mouth, in terms of hormonal interplay, in terms of human experience, is completely different.
Right. So next question is, my baby prefers more of my right breast and cries when I bring him to my left breast. I can also notice he's on the left head to the side and sucks his left finger. Is there any relation between this?
I'm going to take your attention to pregnancy. In late pregnancy, where was the lie of your baby? How much did he move? Where did you feel your movements? It could be a pattern from a womb lie, that the baby was only able to move or the neck was tilted in a certain way. So there are certain patterns being held. And you can look at that. You can do body work around it. You can look at the birth process itself. What was the birth like? Was it induced? Was a vacuum used? Was it vaginal? How long was the pushing phase? How was the baby lying? So they're carrying these patterns from that time, which then are held in their bodies and affect. And also, are you massaging the baby? How old is the baby? Are you massaging the baby? What is the quality of that massage? Are you doing it or is somebody else doing it? So there are many ways of doing the release. So just, and I already did talk about that a little bit, keep the baby close or massaging the baby with your own hands, making eye contact, talking to it. We want to integrate, let the baby integrate a process or move through those experiences. And then also helping the baby keep the neck in the opposite direction, which means by play, not by forcing. So you're taking things to the right and encouraging the baby to turn to the right. So if the preference is the left, we're encouraging them to move. You go and sit on the right, come down at eye level and talk to them at that level. That will engage them. And you're using their own ability to engage. So, we talk about these parent-infant pathways, the different pathways with which the baby connects with you. If you educate yourself on them, and then you use those to encourage the bodily movement of the baby, like a playful exercise, if you please, you might be able to eliminate some of that causes. But a good body worker can also do it. It could be fascia, it could be a muscle pattern, it could be just a pattern from the womb of birth that's keeping the baby that way.
Right.
We can release it.
Next question is, why does the baby prefer only one breast over another?
There are many reasons. One of them could be the lie, but the other could be that we are left-handed or right-handed. Preferences are just that. We can't explain them. Just like there's not symmetry in the body, left can be bigger than the right. They can have different ducts. They can have different flows. All this is in the realm of normal. So, what is it that he enjoys? So, say if the baby enjoys being on one breast, say on the left, and the right, they're not taking to. Which means this is the lie that is comfortable for the baby. Then can I bring the baby in a football hold on this side? So the lie stays the same. While I work on the baby's physiology and body and mind and acknowledging their experience and looking back into that, it's quite every step of your journey from conception to this point is your history as a baby. It's an unspoken history. It's an unacknowledged history, but it is still history. It's interesting that we're talking about this because we have a whole program on My Child First called The Sentient Baby. It actually talks about this, of how your baby is receiving the world, and that is shaping not just his personality and his faculties, but also the very body that he has. And we're seeing the resonance of that adaptation right here in breastfeeding.
Right. Please put some light on breastfeeding with flat nipples. And also my supply on left breast is low compared to right.
So flat nipples may be challenged in latching. And that also too depends on the shape and the size of the breast. So some people with flat nipples, with big breasts and soft breasts, the baby can easily take the breast tissue behind the nipple and then pull the nipple. For others, it may be a challenge. Basically, that nipple needs to go in the mouth and get elongated in the mouth as the baby sucks. Now, if instead of going inward, it retracts backwards, the baby loses that grip, and that's the challenge you have. As far as making it right, I think it needs a little bit more closer and detailed look by somebody who's doing it hands-on, because each breast is different, each baby's mouth is different. So a small baby's mouth versus a larger baby's mouth, different result. So it's really difficult to comment on it in a generic way, but acknowledging that there may be a challenge, but it can be overcome. And breastfeeding itself is not a function of the size and shape of the nipple, because the opening is still there. And if supply on the left is low compared to right, and how do you assess it? And even if it is, that's fine, because when we say supply is low, what does that really mean? Because the food is being produced continuously. When the baby is on the left, which is a lower supply than the right, and the baby sucks, there's a letdown reflex. And meanwhile, the body is collecting the information back. And the next letdown reflex would be a different quality of milk, and then a different quality of milk. So I'm not quite sure I can relate low supply on one side. When we talk about these low supplies, it's usually how we pump it out. And so you can say that each breast behaves differently under the action of a pump. I've worked with women who've had a different brand of pump work differently on both breasts. And so that's how it is. So I'm not quite sure I can truly integrate the question of low supply to breast, because that feature that says what is evaluating the supply. And usually it's the amount you're pumping. And you'll find that if you use a different brand of pump, your right will give you less than your left. Because each pump works differently, and each breast needs a different stimulation to do a different thing. But your baby's mouth does everything everywhere.
Next question is, does feeding the baby lying down cause choking in baby?
No, it doesn't. So what are the myths around it? That if you lie down, the baby will get an ear infection, usually. Now tell me something. Now I'm going to give you a very practical demonstration. If I am sitting up and feeding the baby, this is the baby's position, right? And if I lie down, my position changes, but does the baby's position change? So in every case, the baby is lying down horizontally, whether on your chest while you're sitting or parallel to you if you're lying down. Why should it be the problem? Here is the problem. When you lie on your side, your upper breast comes in line with the baby's ear. And in your love, that may drip onto the baby. that might have some ramifications, but lying down in itself will not. So please lie down and feed your baby. It's so much more comfortable to feed them at night.
If we are giving expressed milk, what's the best way to give that? Nipple confusion is again difficult to manage.
Depends on the age of the baby. So I had suggested that don't give breast milk up till 6 weeks, and thereafter you can bring in whatever method. Again, you'll have to choose practicality if you're going to give expressed milk. If you're going to express the milk to make the additional food for the baby so that the baby gains weight, you could use a supplemental nursing system. But if you're going to express milk because you have to go out to work, you might find a different, more efficient way of feeding the baby. Again, don't worry about the nipple confusion after it's a well-established breastfeeding diet. Babies are not stupid. They're not confused. They're smart. So later, when they can distinguish between the benefits of being with the mother and the efficacy of having milk, you can introduce other ways of feeding. Bottles have other issues, but nipple confusion happens really up early. If you have a good established breastfeeding, then it may not worry so much.
Does your routine during pregnancy affect the baby after delivery? Does the baby follow the same after delivery, like sleep and awake time?
Babies have their own sleep and wake times, and post-delivery or newborn period, they follow hunger cues and other cues of their body. Their sleep rhythms are different than adult sleep rhythms. After a few months, they come into this world, they develop a circadian rhythm, and they are now driven by light and dark. So not really, because it's not like you're going to change your routine. You are driven by light and dark, so you will sleep at night. Lots of women will feel movements more at night because they're more rested and the babies are not being jiggled along. And so, no, not really. They develop the sleep-wake pattern inside, and it's unique to them. And they follow it outside, and it's to do with their body's need rather than what you're training them in.
Okay. I have hypermesis gravidarium. I have lost a lot of weight and I have food aversion. Does it affect the milk supply after the birth of the child? And I had HE with my first pregnancy too, and my baby was colicky. Does it have any connection?
I am not aware that there is a connection. Firstly, this is happening in the first trimester, so I don't know how far in your pregnancy do you feel this HG, and it's supposed, it starts with a morning sickness. It's called a morning sickness, but we know that it affects people differently, and this is a really extreme case of that. So no, I don't think there is a connection between breastfeeding and this. This is an adaptation of your body to the pregnancy, how it perceives the pregnancy. And colicky babies have more to do with stress and environmental than to do with what you had in your first or second, third trimester, though some patterns are carried. Now, how are you working through the HG? What is your emotional state or your mental state like? That leaves an imprint on the baby rather than what is happening itself. So I'm going to ask you to pay attention there. Are you bonding with this baby and letting the baby know what challenge you're going through, but it has nothing to do with him? Colic is a overstimulation burden on the body. Nobody has explained colic. I've tried to explain it through the lens of the neural development or the neurobiology. And colic is a response to a stressful environment, whether internal or external. That is why it usually happens in the evening when babies are overstimulated or mothers are anxious. So you might want to follow the baby's rhythm to take care of colic, or offer them certain amount of intervention, which is either walking around or movement, what might make them feel safer, and then that may help colic. So it's two different things. As far as I know, it's two different things. If you find out anything, we'd love to know as well.
Next question is weight loss and breastfeeding. Can you explain, please?
Yes. So breastfeeding or making milk and feeding the baby takes a certain amount of energy in your body, and that happens to be 500 calories per day for an exclusively breastfed child. If you lose 500 calories a day for 7 days, you lose half a pound. That's how you do weight loss. You make a negative calorie balance. A negative calorie balance is not a negative nutrition balance. Please understand that. So you don't give up food. You give up food high in calorie, low in nutrition, and you have highly nutritive food and no extra. You feed your body, you nourish your body. So you feed it in terms of calories that you need to sustain normal function, and you nourish it with good nutrition. And the fat that you collected around your hip and thighs is what is burnt to actually fuel breastfeeding. So weight loss.
Great. Each time I breastfeed, he bites and get the hold, but it's painful and it makes my nipple with blood and
so that's a bad latch. That's a typical example of a bad latch. And over a period of time, your baby grabs onto whatever he can because in his point of view, he needs to get to the breast to feed and survive. So his reflex is going there. So if he's grabbing onto it, he just wants to make sure that you don't take it away. And that's why he's using force. So you have to repattern that brain and that experience by getting him a better latch. And because that will not be painful for you, you will not feel the winds. He will feel a different experience. He will feel the flow of the milk, and then he will learn a new way of latching on. So it will need a little bit of effort on both your parts.
Right. So just a couple of more questions which we got now.
Yeah.
Someone is asking, will flat nipple affect breastfeeding? Can we use nipple puller? How to use it?
You can use a nipple puller, but nothing is more effective than the baby's mouth. So you can use a nipple puller to protrude the nipple and then get a latch. You can. Sometimes it's effective. Sometimes it's not, depending on what pressure is needed. What are your tissues like? So the idea is to work with a consultant to get a good latch, and then the baby's mouth will act as the suction to pull the nipple.
Right. For better weight gain in babies, should we feed every time in only one side of the breast so that baby takes the hind milk?
Yeah. That thank you for bringing it up. I should have mentioned it, but I think it's kind of self-explanatory that you put the baby to the breast and let the baby finish the feed from that side, which means he delatches or goes to sleep on his own. And then when you may want to put him upright to burp him or just soothe him, and if he looks for more, you put him on the other side or on the same side, depending on what your instinct says. Before 5 days, 1, 2, 3, 4, and 5th day, you can switch breasts because you're stimulating both sides, especially during engorgement. As you feed on one side, the other one will fill up even more. So you might want to switch. But after day 5, that is the time, after it's settling into a routine, you feed only on one side till the baby leaves it. And then you shift maybe to the other side or to the same side using your common sense approach.
Right. So Prashantini, we have already covered this topic on how long we can breastfeed, how to breastfeed after C-sec. I'll move on to the next question. If the baby sleeps during day and night, is she not waking up for milk? Is it compulsory to wake the baby up and give milk if baby is sleeping for 5 hours continuously?
How many times a day is the baby sleeping 5 hours? It's a comprehensive look, not just one number. So is the baby feeding in 24 hours between 8 and 14 times? Is there enough urine? Is there enough potty output? And is the baby gaining weight? If so, and your baby has a pattern of sleeping 5 hours, be grateful and enjoy your sleep. But if you find that your baby is just not waking up and each time it's a struggle waking up and he's not gaining weight, now that's the problem. So the question isn't 5 hours. The question is that is the baby inputting enough in 24 hours, whatever their rhythm is. So after 5 hours, the baby wakes up, feeds, then plays for an hour, asks again, then plays for another 45 minutes and asks again, then sleeps again for 2 hours. Then that's fine. But you've got to look at the big picture. Not every moment scheduled. Big picture. What does my baby like to do? So even as adults, we are not monophasic in sleep. Some of us take 2 naps and some of us are polyphasic, though a lot of emphasis is put on 8 hours of sleep or 6 hours of sleep. But lots of people don't sleep. And they live with this own story and stress of that story. Oh, I didn't get 8 hours of sleep, or I didn't get 6 hours of sleep. I just sleep well. What does that do to you? If you understand your own rhythm and your own pattern, and you wake up feeling refreshed, rejuvenated, you have good digestion, you're eliminating on time, that means you're healthy. And if you need 2 times sleep, then sleep. So same thing, let's show the same kindness. I mean, we are not showing kindness to ourselves enough. My God, we should. But to children as well, to say, okay, show me what is your story. If the story sounds like, oh, this is this baby's story, then great. And if the story says, my God, this baby is not telling a story because he needs help, then get him. I hope that makes sense. Because this whole fragmentation to bits and pieces that are measurable without context is actually stressing parents out.
Right.
So instead of worrying about what the baby is doing or not doing, look at the broad parameters of health. Does the baby have a rhythmic sleep and wake cycle? Spontaneously asking for, is he asking for food? He's not asking for food and sleeping, and then I'm worried, no matter how good your baby is. Is the baby inputting and outputting enough? Is there growth and development enough? Are there opportunities, and we talk about this in our parent-infant pathways, is the baby interacting? Because one of the pathways of knowing health is the social baby. So you're looking at a lot of things. Is his digestion working well? Is his elimination working well? These are bodily functions. If they're all working well, then you're doing fine. And if they're not working well, then you don't have to fix the baby. What you're looking as a symptom is of something the baby is going on with the baby. So we have to help the baby, not fix the baby.
Right. So someone is asking, what's the procedure for breast milk donation?
I think there are bodies who accept that donation. Maybe they have a clearer guideline on it. I really don't know that aspect.
Yeah.
If you heard my language, I'm a breastfeeding proponent, so it comes from the breast, but it's a very noble thing if you want to. Is there an agency in your city, in your place, which collects? And it'll be really worthwhile getting in touch with.
Yeah. The next question is, can we use spoiled milk for massaging, milk bathing the baby? People say it's good for skin. Is it true?
I don't know. Those are questions I haven't yet asked or answered or seen any. I haven't gotten any information.
I'm just quickly moving on to the other questions. We're really over time right now. My son is 11 months old. He rejects my right side breast, even in sleep. I had expressed milk from my right side for 2 months due to my sore nipples. Please tell me the connection between these two situations.
Okay, that was too quick for me. I hear slowly.
My son is 11 months. He rejects my right side breast, even in sleep. I had expressed the milk from my right side for 2 months due to my sore nipples. Please tell me if there is a connection between these two situations. So he is rejecting the right side breast and even in sleep, and she's expressing the right side.
Can and cannot have, I can't really say. Well, let's check with the baby, should we, at 11 months. So maybe you have a conversation with the baby saying that what happens, when you're here. So his rejection is a communication. But what is he truly saying? And maybe you can talk to the baby, and when you put the baby to the breast, saying you don't like it here, what do you not like? What do you might find that in that conversation he might come onto that breast. Or change the position and see maybe from a cradle hold to a football hold. We're just going to explore the different ways that the babies come onto the breast to say, what is this symptom telling me? And there could be a connection.
Yeah. Next question is, I have extreme pain.
I'm also just curious, just because I have a pre and perinatal psychology background and I'm interested in trauma. When you were expressing from that side, what did you tell the baby when you didn't latch him on that side, that this is hurting mommy? And he might be still holding that idea that if I go on that side, it may hurt. You might still be protecting mommy. So there's I'm just curious. These things are absolutely true. I've seen them time and time again in sessions that we do for trauma and with babies. So it's interesting what you may have said at that time when you had said, don't drink from this side. And maybe now telling him that it's okay to drink from that side rather than forcing it might help him. And just a thought.
Yeah. Nikita is asking, I have extreme pain in the first 1 minute of pumping in both the breasts. What should I do?
pumping, that's when the nipple is being pulled, right? Um, um, it's beyond the scope of what I can tell you because it's not a general issue. Maybe a consultant can help you. There are certain things that even are beyond the scope of my work, and I'm happy to say it here so that you can get the required intervention and help as soon as possible. There's some really fabulous breastfeeding consultants and counselors here. We have them in our country now, so you can reach out to them.
Right. Next question is how to feed twin babies.
Challenging task, but possible. You can feed them simultaneously. The only thing is that your time will increase. You can put them, you'll need help in latching, but you can put them both together on both sides. You can look at ways to latch them both together, both in football hold or one over the other, or one this way and the other one this way. And if you can, if their timings are somewhat matched, you might feed them simultaneously, and that might help. If that gets too much, you might feed one express and give to the next one and then rotate that. There are many ways to achieve it. But it is, I want to acknowledge that it's a lot of hard work, physically involving work, because there are two babies and two rhythms to follow.
Right. Amulya is asking, can we feed the baby when he's hiccuping?
Yes. Yes. They would probably close their eyes, but we're not quite sure they're sleeping or not. Because they're still in charge of their suck, swallow, wait, and start again.
Right.
But if they're showing cues and they're not fully awake, definitely you can feed. You can't feed a baby who's not showing a cue. They're already showing a cue. That means their body has told them that they're hungry. You can't feed them.
Right. 11 months old baby sleeps only with breastfeeding. How to train him so he learns sleeping without breastfeeding?
What happens when you don't? What happens when you don't put him to the breast while sleeping? So find ways that might make him feel secure, safe, which could be, because sucking is the soothing activity that lulls you into sleep. What else could it be? It could be a tiny, a stroking, it could be a lullaby, it could be rocking. But they do need some kind of soothing mechanism to actually drop into sleep, especially when they are so distracted with everything outside. So make a bedtime routine. Perhaps this question can be answered somebody who understands sleep better than anything, because I do understand that soothing themselves to sleep, they're using the breast as a soother to calm themselves. So anything that will help them calm themselves will help them transition into sleep. That's how I see it. I mean, it's a very practical way of seeing it. I can't really suggest a routine.
Right. Naga Ashwini is asking, my baby spitting more after most of the feeds. Now that she rolls over, it's more. How to avoid excessive spitting and how to identify spitting and vomiting?
Have they had it also? I mean, this kind of spitting could be symbolic of something else going on. So maybe they need an evaluation of why this is happening. Some amount of spitting is fine, but if it's too projectile and it's too much, you just want to eliminate that. Is there something else going on?
Right. Okay.
Our spitting is also controlled by the different sphincters in our body. So what's going on actually? And it may be completely benign, but it's still a good evaluation.
Next question is by Aishwarya, and she's saying, can we feed baby directly on one side and express from the other side simultaneously?
Try it and let us know. You can, I mean, there's nothing wrong with it, but think of what is going to happen is when because the breastfeeding is such a human experience, and having a machine on the side would be very distracting for the baby and for you. But you could try it. It depends on how much of a pinch you are in and what needs to be done. There are no rules, and you are in charge of your own parenting paradigm. So experiment and not judge, and see what works for you.
Right. Shivara is asking, is it okay to use pacifier? Does it affect breastfeeding?
Yes, it does. And the question you should be asking, as the name says, why does my baby need pacifier? Therein lies the crux, the cause. The pacifier is the band-aid on the symptom. The symptom is that I need to suck. Why does my baby need to suck so much? And then evaluate that and see if you can help the baby regulate better, and if you can meet some of those needs more, you can some amount of therapeutic intervention. And even then, because pacifiers basically change the oral anatomy, they push against, and a lot of stuff is going on. So there'll be other issues that come up with pacifiers.
Right.
So let's do the cause rather than the symptom.
Yeah. So Santi's question we have already answered, Santi, that the doctors are recommending every 2 hours waking the baby up. Is it a correct approach? We've taken that up. I think that's about it.
Could we have some love?
So 3 participants have raised their hand as well. I don't mind if they want to talk and ask their questions. Nitya, Sridevi, Bharti, in case you want to, I'm opening it up for you.
You're opening it up for me.
So any of you would like to just unmute?
Hi, ma'am. I'm Nishana.
Hi.
Ma'am, it's been one of the most eye-opening sessions I ever attended, and I'm so grateful to you for this. I mean, the whole perspective about breastfeeding. You know, I'm actually preparing for my lactation counselor, and I think I'm also a breastfeeding mother. But this whole thing about, breastfeeding as an act that the baby does and not what we do completely changes everything.
Thank you. Thank you for that.
Thank you. Thank you very much, ma'am.
I'm going to request you to send in your feedback to us as messages, and please give us permission to show them around, show off a little bit. We would love this program to reach many people. It's such an important thing, and we're losing something so valuable by just the perspective being so narrow and so different. If we can just help anybody change their point of view, we would love to do it. We also have wonderful programs on our platform for childbirth, for sentient baby, and we're coming up with the parent-infant pathways that talks about the ways babies are trying to talk to us, communicate to us. So do look us up on My Child First and also on our e-learning platform. But most of all, please send us your comments. We can only hope to improve when we hear from you. And if you have a pat on our back, we love that too. Tanvi, anything else you want to add here?
Also, just wanted to add that actually I forgot what I was saying, but anyways, you covered it. That we have these. Yeah, so I was saying that we'll be putting up a calendar of different classes that we will be doing in a month. They will be on breastfeeding. A few would be on massage. So there will be a host of these workshops that we will be doing. Along with the courses that we offer, through our platform. So one of you would like to attend that, you're more than welcome. And thank you for today. It'll be great if you could just send us your feedback through either a direct message on our Instagram or otherwise, through an email. We'll be sending you an emailer with a feedback form. So if you can just fill that up as well, whichever way you're comfortable in just sparing a few minutes to write feedback about the session, that'll be great.
If you're on our social media, just hop in there and send us comments and send us your love.
Yes. So thank you so much, everyone, for attending. That's it from us. This out. Thank you.
Bye. Good afternoon.